I, in the last year, have become a health coach in addition to a PA, and this year I'm going to go forward and do some functional medicine training, which is looking at more of the why and the fact that all the systems are connected. And so anyway, that's kind of my passion at this point. And the eosinophilic esophagitis fits very well into that. So my case study is not in here, but the patient that I want to talk about is a recent patient that came to me. He had presented to GI in the last year with some difficulty swallowing, a lot of reflux that wasn't really handled by, just typical easy measures. And then finally he started to have vomiting and when he was trying to swallow solid foods. So, of course, GI had done an endoscopy and found that he had some eosinophils in his esophagus. Which is known as eosinophilic esophagitis. So then what that is an allergic or inflammatory response over a period of time to things that are ingested. It's a delayed hypersensitivity type of thing. You're not going to see an immediate response. It's oftentimes brewing and developing over years, just like allergies do. You may have years that you have some eosinophils in there that you're not even seeing any symptom. There is some thought, and I think ongoing studies right now that even swallowing pollen, when the pollen is thick in the air, is likely to cause some of these eosinophils to deposit. Symptoms can vary. And this is not necessarily going to be an obvious thing. Like I said, sometimes it's going to be reflux that's not really responding to your normal therapies. Sometimes it's going to be abdominal pain. Sometimes it's going to get to the difficulty swallowing and all the way to the point of food impactions. But in children, sometimes this is going to present as, reflux, and sometimes it's going to get to the point where you're having failure to thrive or you're actually having vomiting. You see the vomiting much more often in children than you do in adults. The foods that can be the triggers are different for each person, and I would say probably a combination of things for most people. However, you can see overwhelmingly cow's milk, dairy is at the center of that. So that becomes something to really think about when you have these infants that are spitting up a lot. Sometimes we're going to move them to a hydrolyzed formula, and that is helping some with breaking down the proteins, but then we need to think about a lot of those hydrolyzed or hypoallergenic formulas are still dairy, and it's very hard to find an alternative formula out there. Soy is, for many reasons, not the better option. And we're kind of limited at this point. But across the board, kids and adults, 74% of people, even if there are multiple triggers, will improve once the dairy is removed. And so it's not often that you have such an overwhelming forerunner there in what's a cause for something, but this is that. And oftentimes people, if you start questioning them, will have a history of, intolerance to milk, or they'll say, well, I can eat cheese, but I don't really do well when I have liquid milk specifically. And you see the same in the children and the infants. The parent sometimes has had a gut feeling about this, but we all know milk, it does the body good, and you keep feeding the kid the milk because that's what you're supposed to do so that their bones grow. But this is a big, big factor, and a lot of the times, even if there are other minor food triggers, removing the dairy will really make a big difference. Wheat comes right behind that, and so that's kind of at the forefront of a lot of research at this point is how do we get reliable testing to really know what this is, and we're going to talk about that in a minute. The other triggers, this comes down to, again, our top allergenic foods. Egg and soy and nuts and shellfish are in there too, but overwhelmingly it's the wheat and the dairy. So the way that we get to the diagnosis, sometimes this is a years-long process. Symptoms may present, they may be infrequent, they may be worse seasonally for those who are being affected by the pollen, and then they kind of go away, so it doesn't seem like as much of an issue. But once they make their way to the point of getting an endoscopy, there are actual visual changes that they can see on endoscopy, but the gold standard for diagnosis is several biopsies throughout the esophagus. I forget, MEOC GI guy that said years ago it should be 6. I would say some of the GI I'm not seeing necessarily that there have been 6 biopsies, but that's apparently the gold standard. Once they have the diagnosis, unfortunately, the only way to know if there's progress in treatment resolutely is to have them go back for the endoscopy and have more biopsies. I would say for the most part, we usually end up going more on symptom and resolution of their problems, not necessarily repeated biopsies, because obviously, especially for children, that could be difficult. So, you're always in your differential diagnosis looking for, are there other reasons for the esophagitis? Standard GERD is an issue. One of the most common, the PPIs and the H2 blockers are some of the top prescribed medicines in our country today. And ironically, once you give the acid blocking, then they actually have more problems digesting their food, and it's sort of a vicious cycle. You get more of the reflux. Other forms of esophagitis, obviously illness. Then you can tend to get some esophagitis often for several months after. Infection ongoing, think of things like H. pylori infection and then irritable bowel. So how do we determine what it is that's causing this? When GI sends patients to us, or if you suspect this and send patients to us, we're going to do our standard skin testing for foods just like we would if they had an anaphylactic reaction. That's kind of our jumping off point, and sometimes we don't see that with our synthetic testing or the testing off the trays. But then when we introduce a real food prick, where you pick the pick in the real food and then scratch it on them, oftentimes that will elicit more of a response. We do also then pair that with IgE blood testing a lot of the time. The way I like to explain it to patients is we don't necessarily just go on the IgE testing, because if you take 10 people out of the waiting room or 10 people out of here, there's going to show to be some IgE response to multiple foods sometimes that are not necessarily causing any issue. But when we pair that with our skin testing and then sometimes with patch testing, we kind of use that as a jumping off point maybe for an elimination diet. The patch testing we don't use as much. We prefer to go with the first 2 options. That is actually like our patch testing for contact dermatitis. We're going to place some of food, or sometimes we're doing powdered milk, that kind of thing, on the patient in a little thin chamber, and then you send them on their way and have them back in a couple of days. How effective are each of these? The reason that we're using all of this whole picture is because a lot of the time we're not getting a clear answer. Now, that being said, going back to the dairy, wheat, etc., when they do studies where they actually are taking the biopsies serially, they do get a clear picture. We're not necessarily seeing that every 74% of patients that are coming to us are coming up to skin testing for milk, but we know that, again, when they're looking pathologically at the biopsies, there is improvement. And again, the blood testing, sometimes there is some immune response, and in normal people who are not having symptoms, so we take that with a grain of salt, and it's just part of the picture. But oftentimes, if nothing's showing up on skin testing, we'll take the top things that are showing up on the IgE. And specifically then we have these component testing now that are breaking down the specific proteins, and oftentimes that will elicit more of a response than what you would even just get from the IgE milk or whatever on the standard test. And the patch testing, I would say that probably that's our third choice. Sometimes it does become obvious, and that's a helpful thing, but it's definitely the third thing that we go to. So as for treatment, the standard is to give a PPI. Sometimes we use corticosteroids. We even use some of the asthma medications and actually have them swallow. So it's a same kind of effect as your inhaled steroids, but just you're getting it into the esophagus instead. Again, going back to my preventative desires, that's a Band-Aid effect. You really want to get to the trigger because you can put the medications in there and you can slow down the inflammation and the excess acid production, but you're not necessarily fixing the problem. So when we're talking about empiric versus specific eliminations, again, going back to the slide, we know that the top 6 allergens that we are concerned about for eczema and anaphylactic allergies correlate with this. So, if testing is not leading us the way that we want to go, then we'll often start an empiric elimination. Specific, we're going to guide, the patient to their 2 or 3 things that they need to eliminate based on the testing that we've found. But oftentimes, this is taking a deeper history, and when you really start to get into the nitty-gritty of talking to them about food intolerances that they may have suspected in the past, there oftentimes is an inclination with a patient to just kind of brush, again, milk, wheat, these are all things that are part of our standard diet, and we'll brush it under the rug and say, I do think actually that I do get some bloating or stomach ache with blah, 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 but I just figured that was, and they attribute it to something else. But oftentimes when you get down to that deeper discussion of kind of their lifestyle and their history, and sometimes you get back to, this all started after I had a really stressful time when I was in grad school and blah, blah, blah. And you start to see, and then I actually had more nasal allergies at the same time. And so, a lot of the times we can correlate it with some of the other factors in their allergic history. Sometimes this is their only thing. This my patient, my guy that I said for the case study, this is his only thing. He does not really tend to have nasal symptoms. So he thinks of himself as a healthy guy until this started happening. So anyway, if we can get to a specific elimination, then obviously we'd like to do that because that's a lot easier for people to do than take out the main foods that tend to be part of the staples of people's diets. Oftentimes at GI, they're having to get to dilation when that inflammation in the esophagus gets to be to the point where the anti-inflammatories are not opening the esophagus enough, or if there's that much difficulty swallowing or vomiting, they're having to do dilation. And again, that's a temporary thing. If you don't remove the triggers, oftentimes you're going to end up back there 2 or 3 years later. There are new medications coming. I think Dr. Roop is going to talk about that in a little bit. Does anybody have any questions? Yes? Antihistamines like our Zyrtec, Claritin, Allegra. You're going to get some relief with that, just obviously the part with the pollens being a factor, but they're really not, you're not going to get the inflammation, the treatment of the inflammation with just the antihistamines. And like I said, a lot of times this is coming with standard allergy and other things, so they're often on those medications already. Singular, I think part of what Dr. Roop's going to talk about is some of the other immunology that's coming into the picture now. But singular is not one that we use readily to make a big difference in EOE. Any other questions?